Thank you. It's an honor to be here today. I'll be replacing Dr. Goldstein, who could not make it and sends his regards. Be talking today about radiosurgery. I'm a radiation oncologist. I think radiosurgery is best delivered in the multidisciplinary setting, and none of this would be possible without Dr. Goldstein and the other surgeons at Baylor under the leadership of Dr. Klintbaum. At the Radiosurgery Center, we have two machines, a CyberKnife and a Gamma Knife. The Gamma Knife treats only the brain, but the CyberKnife is much more versatile, is able to treat head to toe. Radiosurgery itself is to ablate by means of precise high-dose radiation to intracranial and extracranial tumors, lesions that cannot otherwise be treated surgically. Generally, it's given in 1 to 5 fractions. When we treat body lesions, it is also called by many stereotactic body radiation therapy, or SBRT. The CyberKnife itself is a 6 million electron volt linear accelerator mounted on a robotic arm here. Peritumoral fiducials are placed by interventional radiology or via laparoscopy. The CyberKnife, by fluoroscopic imaging and by infrared markers on the chest, is able to track the tumor during treatment. And for these tumors that move with respiration, while the beam is on, you'll actually see the CyberKnife move with the tumor. It's an outpatient procedure. Each one takes place over about 1 hour. Today I'll be talking about the use of radiosurgery in hepatobiliary cancer, in hepatocellular cancer in 2 categories, the unresectable cases and as a bridge to transplantation, talking about liver metastasis and briefly about cholangiocarcinoma. Hepatocellular cancer, you all know worldwide, it's a major problem. Overall survival is poor, but it is potentially curable via transplantation or hepatic resection. Unfortunately, not all patients are able to undergo those. And since April of 2005, we have integrated radiosurgery into the care of patients with hepatocellular cancer at Baylor, in both unresectable and while awaiting organ transplantation. All patients were evaluated by a liver transplant surgeon, Dr. Goldstein, prior to radiosurgery. Fiducials, as stated before, were placed, and respiratory tracking was used with the CyberKnife robotic radiosurgery system. The median dose was 42 gray. There's quite a range of dose as our experience and comfort level with radiosurgery became greater. They receive it over 3 consecutive days in 3 fractions. We typically follow up patients at 3-month intervals. We determine response by RECIST criteria or, in a few cases, explant pathology. For radiosurgery planning, we take the gross tumor volume as contrasted, as seen by contrast on CT or MRI. We add about 10 millimeters around that, and then we add about another 0 to 3 millimeters, and that's where we prescribe our radiation dose to. As you can see here, with time and our comfort level, our radiation dose has increased. We now aim to give between 54 and 60 gray in 3 fractions to the tumor. So in order to do this safely, we need to respect our normal tissue dose constraints. The liver here, in over 200 cases, we've never seen a case of radiation-induced liver disease when allowing 700 cc's or more of the liver to get less than 15 gray. And we also are particularly concerned about the esophagus, stomach, duodenum, and bowel. We've treated a total of 32 patients with 36 tumors at Baylor with radiosurgery. 24 patients were unresectable, and 8 patients were treated as a bridge to transplantation. The unresectable patients, as you can see, tended to have larger tumors. The treatment overall is well tolerated. 25% of patients had acute toxicity. There was no grade 4 to 5 toxicity and no cases of radiation-induced liver disease. Most of the toxicities are relatively mild: nausea, fatigue, some abdominal discomfort. There was 1 grade 3 toxicity, a hepatoduodenal fistula, which I'd like to illustrate further. This is a gentleman that had a large right hepatocellular cancer. He had undergone chemoembolization twice. Biopsy revealed a recurrent tumor, and as you can see here on the CT, a large mass here. We gave 35 gray to the 68% isodose line. About 4 months later, he developed bacteremia, nausea, and vomiting. CT scan revealed an air fluid level in the mass, a fistulous tract to the duodenum. Ultimately, he underwent laparoscopic gastrojejunostomy. Fortunately, at the time of surgery, biopsy revealed no tumor, and ultimately the patient went on to live 20 months following radiosurgery. Overall local control in these patients is good, 87%. Most of them tend to have stable disease, about 25% decrease, and we have had one complete response. Survival in these unresectable patients treated with radiosurgery at 1 year was 43%, 2 years, 21%, with a median survival of 11 months. This is an illustrative case. This is a 57-year-old gentleman with hepatocellular cancer. He had undergone previous chemoembolization to this area here. This tumor is just the tip of the iceberg and invades the portal vein. This did not respond to chemoembolization, so we administered radiosurgery. We see here 42 gray delivered to the yellow line. This line here is 15 gray. And we see at 3 months, we see the treatment effect based on where the beams enter the liver here on T1 contrast enhanced images, the tumor remaining the same size. At 6 months, we see further radiation reaction, and at 1 year, we actually see the tumor remain stable in size by RECIST criteria, and we're starting to see capsular retraction, interestingly, from where the radiation beams entered, and there's just an illustration of that over time. Here's another case. This was actually the same patient, otherwise I think this would be resectable. This tumor received 54 gray, 18 gray times 3, you can see there. And over time, an excellent response to the treatment, with a good response in the tumor and the hepatic capsule retracting. This patient is doing well now 14 months after treatment. Here's an example, often asked how large a tumor can we treat. This is a gentleman that had obviously an unresectable tumor. It progressed despite chemoembolization, and we administered a lower dose due to the size and normal tissue constraints. But ultimately, the tumor decreased in size. The patient lived 7 months following CyberKnife and did have relief of his pain and I think effective palliation. This is in comparison of our series to a recently published series from Princess Margaret Hospital. Phase 1 trial, they administered 36 gray in 6 fractions, which is a lower dose than what we've tended to give, 42 gray on average in 3 fractions. Our local control in our series was higher, median survival and 1 year survival essentially the same. I think more interestingly, actually, is CyberKnife or radiosurgery in general is a bridge to transplantation. We've had 8 patients who underwent radiosurgery and ultimately underwent transplantation. The median time from radiosurgery to transplant was 90 days. On explant pathology, 3 of the patients had a complete response. 6 of the 9 patients had residual hepatocellular cancer, but in 2 of those, there was just a small millimetric focus of disease. And based on size, all of the tumors were decreased or stable when comparing the preoperative radiographic imaging to the maximum size pathologically. This is the 8 patients that we have done so far. As you can see, the doses have increased with time. I don't see a clear correlation with tumor response and radiation, and we're currently, this manuscript is currently under review. The survival in these patients with a median follow-up of 39 months, all patients are alive and free of disease. So in conclusion, for hepatocellular cancer, it's well tolerated with appropriate dose constraints, provides good local control, and as patients are waiting for their liver, it's feasible, well tolerated, and on explant pathology has excellent local control and may enable patients to remain on the wait list during the long wait for organ availability. Changing gears a little bit, liver metastasis from colorectal cancer, also a major problem. Surgical resection has been thought to increase survival. This study by Fong, 456 patients underwent hepatic resection, 5-year survival 38%, median survival excellent at 46 months. Here's a large series, 18,000 patients, and 33% 5-year survival with resection and 11% 5-year survival without. Fortunately, not all patients are able to undergo resection, so radiosurgery has commonly been used in these patients. We reviewed our first 25 patients. By now, we've treated over 100. And in the treatment of these 25, there's excellent tolerance. Only 32% had acute toxicity. All were equal then or less than grade 2. And there were nausea, fatigue, and some cases of skin erythema where the beams enter. Interestingly, 85% of patients had a CEA response before and after radiosurgery, from a value of about 10.4 before radiosurgery to 2.4 after. Here's a case, a 59-year-old female had a solitary metastasis in the liver. CEA was 63. We administered 54 gray, and 9 months later, excellent response, and the CEA was decreased at 2.6. Here's a larger tumor in the hilum, 6 centimeters, was receiving chemotherapy without response. We gave radiosurgery. As you can see, some of these tumors here, we've actually not had any problems with the vessels of the hilum in the liver, but we do need to be careful with particularly the viscera, such as the esophagus there, as you can see on the corona. This patient received 43.5 gray, slightly decreased due to the size, but at 6 months has had an excellent response to the treatment. Radiosurgery frequently at Baylor is used as an adjunct to other treatments such as RFA, chemoembolization. Here's a case where a patient previously had a radiofrequency ablated lesion here. There was a recurrence at the margin, and we treated it with radiosurgery. And at 6 months, there's an excellent response thus far. You can see the tumor decreased in size and the radiation reaction around it. In a multi-institutional trial recently published, 47 patients with 1 to 3 liver metastasis. The local control was excellent. At 1 year, it was 95%, and at 2 years, it was 92%. Median survival was 20.5 months. For liver metastasis, it is safe and well tolerated. High percentage of patients had a decreased CEA. Local control is excellent with higher doses in the range of 54 to 60 gray given in 3 fractions. Our experience is a little smaller with intrahepatic cholangiocarcinoma. We've treated 10 patients with a median dose of 51 gray. 3 patients actually had prior radiation therapy, and we gave CyberKnife Radiosurgery as a boost, 24 additional gray. Median follow-up is 12 months, median tumor size 4.3 centimeters. It's a heterogeneous group of patients. 4 had chemo before, 4 after, and 1 before and after. Again, it's tolerated well, about 30% of patients having acute toxicity. Local control of the 7 patients available for evaluation was 85%. There was 1 patient actually had a recurrence 13 months after receiving 51 gray and was retreated 28 gray with no acute toxicity. Whether chemotherapy was given before or after had no effect. In summary, for all these patients, radiosurgery for primary and secondary hepatic malignancies, I think a multidisciplinary team, including surgeons and radiation oncologists, is essential to safe and effective radiosurgery. It's well tolerated in the treatment of non-operable hepatic malignancies. Local control is good, and we find it to be a useful adjunct to other local modalities. Thank you.